Good afternoon, ladies and gentlemen, and welcome to the Trellis Health PLC investor presentation. Throughout this recorded presentation, investors will be in listen-only mode. Questions are encouraged and can be submitted at any time using the Q&A tab that's situated on the right-hand corner of your screen. Just please simply type in your questions at any time and press send. The company may not be in a position to answer every question it receives during today's meeting. However, the company will review all questions submitted today and will publish those responses on the Investor Meet Company platform. Before we begin, we would like to submit the following poll, and if you would give that your kind attention, I'm sure the company would be most grateful. And I'd now like to hand over to CEO Monique Fayad. Good afternoon.
Good afternoon. Good afternoon, everyone. Pleased to meet Monique Fayad. I'm the CEO of Trellis Health, and we're delighted to be presenting our inaugural annual results this afternoon as a publicly traded company on the AIM exchange. Presenting today with me, I have co-founder Dr. Marla Dubinsky, who is also a director at the Mount Sinai IBD Center, and we also have CFO Richard Evans. So if we can continue to get started, we can go right into the presentation. Thank you. And I'll advance the slides. Wonderful. So just as a quick overview for those who may be new to the company, Trellis Health is a resilience-driven digital health solution for chronic conditions, starting with inflammatory bowel diseases, which covers the two diseases of ulcerative colitis and Crohn's disease. We have the proprietary license to a methodology from the Mount Sinai IBD Center, which has been proven to have tremendous outcomes in terms of improved quality of care and health, as well as reductions in expensive unplanned care and hospitalizations. We have built out our proprietary Trellis Elevate platform that enables us to coordinate care with our patients as well as their GI providers, which we'll speak about in a moment. And we are servicing both the B2B as well as the direct-to-consumer markets with our connected health solution. Our license from Mount Sinai actually includes IBD as well as 7 other chronic condition categories. So we are evaluating expansion beyond IBD into other chronic conditions, specifically irritable bowel syndrome, which I'll speak about in a moment, which is very similar in terms of its symptoms as well as emotional burden. So a little bit more about Trellis and how we're different from other solutions or, say, apps that are out in the market right now. Trellis is a comprehensive solution that combines both team, tech, and touch to address the needs of our chronic disease patients. And we actually, what's different from Trellis and all of these kind of other apps that are just addressing reactively things like stress, anxiety, depression, is that we look at the disease in context, and we approach the patient holistically to address what their challenges are and assess resilience, and then build resilience using a proven methodology. So how we do this is through a combination of an integrated resilience team, which consists of a resilience coach, a dietitian, and a nurse patient educator, who utilize our Trellis Elevate platform and app to deliver a number of digital tools and care coordination with the patient's GI doctor. So the goal of this is to, again, coordinate, first assess resilience, and then coordinate care so that the patient stays healthy and stays out of the hospital. I'd like to turn it over for a moment to Dr. Marla Dubinsky, who is a co-founder of Trellis, to talk a little bit about the data behind Trellis. And actually, this data was just newly published last year in November and shows actually improved outcomes beyond what was originally published in 2020. So Marla, why don't you take it away?
Sure. Good evening, everybody. As Monique noted, Trellis Health is a connected health solution that really sees patients through the lens of resilience. Now, a lot of people have not associated resilience per se with chronic condition. It's typically related to your employee resilience or maybe patients who have some sort of post-traumatic stress disorder. But what we've been able to do is myself with my co-founder, who is the inventor of the method that uses resilience and positive psychology principles to actually implement behavior change in patients with chronic condition. When you're 18, 19, or 20 and diagnosed with a lifelong condition, it's difficult. It's hard to overcome adversity. There's enough adversity going on in the world, let alone adding a chronic incurable condition. So what is resilience in the face of having a chronic health condition? There are 5 core targets that the Trellis method actually focuses on, because all 5 of these must be and fall into the resilient domain in order for patients to actually have the outcomes we see every day at the Mount Sinai IBD Center. This is an approach we're using analog day to day, using our team at the Mount Sinai IBD Center. It's very unscalable, and we don't have the ability to actually bring it to patients at a more democratized or all access to patients in the country and beyond who have IBD. So what we showed here, and we published, as Monique noted, in November, is that when you target these 5 areas of behavioral or emotional or brain health in someone who has a chronic condition like IBD, not only do you get them to graduate and actually improve their resilience, but as you improve someone's resilience, you actually have the result of lowering the amount of unnecessary or unplanned healthcare utilization, which comes to a large reduction, obviously, in the cost of care. So what we showed is that when we took the same patient and we compared them to the year before they enter the resilience program compared to a year after they enter the resilience program, we were able to see a significant drop in emergency room visits, unplanned, of 71%. Hospitalizations by over 90%, almost 95% of patients. We had opioid reduction, almost 50% of patients had an opioid reduction. And of course, corticosteroids, steroids, which has a lot of side effects and actually impacts the long-term prognosis of patients, that was reduced by over 70%. And this happened in the same patients before they entered the program, built their resilience, and then went on to maintain their resilience, and they were able to change their healthcare behavior. So what we do is, as I noted, every day we still manage our patients at the IBD Center with this methodology, but as I noted, very unscalable, hard to democratize. So what the story was is that Trellis, by licensing the method, is able to use their digital technology and their tools and the platform that Monique alluded to, where we are able to quantify one's resilience on a scale of 0 to 100, make the designation that someone is low or high resilient, create these resilience playbooks, such as a curriculum that takes place over about 6 to 8 months. This isn't something you go to one of those apps that Monique was showing, a single app, you're stressed, here, use this, and your stress is going to be reduced. No, what we're actually doing is we're preventing anxiety and depression, because we're giving people the toolkit, the tools, the skills to actually learn resilience. Resilience is one of the few behavioral health things that you can actually learn and be taught. So after we've decided you are low resilient, we deploy these modules that are all digital and interactive. And in your back pocket, you have a team, a resilience coach, an IBD dietitian or a GI dietitian, and also a nurse educator who's there to reinforce the care plan, because there's no way someone who has low resilience is going to be able to do this without the team. We all know we need someone to hold our hand as we go through in the face of chronic condition, and then we maintain them and track them and monitor them very closely to make sure they are sticking to their plan and they stay well. What is also interesting, and Monique will get into sort of how we're going to be able to expand pretty quickly using our new sort of delivery of our solution, shall I say, and Monique will get more into that. But what's very important is that there are 2 very large gastroenterology conditions that most gastroenterologists deal with. Maybe up to 70% of their patients walk in with either IBD, which is about 1% prevalence here in the UK, as well as any westernized country. And then you also have the other remaining percentage of our practice, which is about 10% of the US population, similar westernized population, is irritable bowel syndrome. Often they get confused, actually. There is a letter difference. One is an actual disease that is a genetic disease. It's similar to psoriasis, diabetes, thyroid disease. These are chronic, incurable, autoinflammatory or autoimmune conditions, lupus, the list goes on, diabetes. However, irritable bowel syndrome there is no genetic cause. It isn't inheritable. It is not something that is incurable. What you need to do is work on that mind and body, sort of what we call these disorders of brain-gut interaction. There is a disconnect. There is an inability to separate your worry, your stress, your emotional health from your gut health. And so the same principles of resilience and behavioral health, resiliency, skills building applies to both IBD and IBS. And that's why also Monique noted there's other conditions we can apply this to. We are starting in gastroenterology. That's what I do. And our co-founder, Lori Kiefer, she is a expert psychogastroenterologist in the behavioral health space of these two diseases. So I'll turn it back over to Monique, who's going to walk us through how we go out, we automate and scale this process.
Wonderful. Thank you, Marla. And just one thing to reemphasize here, when we're addressing these two markets together, we're talking about a total U.S. population of 33 million and a combined annual health expense of around over $80 billion. So very, very large populations here, helping us to expand beyond the 3 million IBD population quickly based on a disease that is very similar and can be our current platform and business can be leveraged to address this population very easily. So just to refresh everyone's memories in terms of our business model, we have two primary revenue streams. Our business-to-business side of the business focuses on selling into health plans and employers. And the value proposition here is that we utilize the resilience method to predict those patients who will be at highest risk of unplanned care utilization. That's the tool has been quantified to be able to do that. And then we manage the patients and we track them using our platform and through our care coordination to keep them out of the hospital with a goal of saving at least 20% per year on the healthcare costs of these very high cost, high need patients. So we're only charging the payers based on patients who actually do a resilience assessment, the resilience screening fee, or who enroll in active care coordination with us. We don't charge based on every member in their population, only those members that we either evaluate or enroll in our active care coordination. In terms of direct to consumer, we're targeting, again, either a patient directly who can pay out of pocket a monthly membership fee, or we have alternative sources of paying for the patients in terms of patient advocacy groups and pharma or industry. And all of these groups have expressed interest in offering these type of services to patients who desperately need them because they don't have the type of emotional and psychosocial support outside of their just traditional episodic care visits with their GI doctor. So the value proposition to a patient is clearly that they're going to feel better. Their symptoms are going to be controlled. They're going to be in more control of their disease overall, the reduced stress and anxiety and depression. And also, as we saw on the slide previously about the data, decreased opioid use and hospitalizations. But really the goal here is for them to feel better and more in control and in power of their disease in their life. So, from an operational highlights perspective, we had a really strong year, our first year coming out, having successfully raised our AIM IPO proceeds of over $40 million. And what we did, basically delivering on what we had said we were going to do with the proceeds, we built out our Trellis Elevate platform, our business, our clinical operation, which was our original care team, which was a licensed clinical care team in New York, New Jersey, and Connecticut. We also established our first B2B contract with the Mount Sinai Employee Health System for a demonstration program with their employees with IBD. And we also continued and started to expand into irritable bowel syndrome by appointing an SAB member who is an expert in functional GI diseases to help assess how we could quickly scale our platform into IBS. That's not to say we didn't run into our fair number of challenges, which is not surprising for a startup, especially during a pandemic. So what I wanted to outline here is that there were a few challenges that we ran into in terms of the contracting process, which we knew would already be long for working with insurers and employers. Typically, these contracting timelines take anywhere between 12 to 24 months, and we had built that into our business plan that we were going to be contracting with them as we got started. Of course, everyone's focus during the last 2 years has been on the pandemic, and that clearly detracted from some attention in terms of pushing these contracts through. But as I mentioned, we did secure our first B2B contract with Mount Sinai, and we got very far in the contracting process with the New York State health plan for a demonstration program with their IBD population. One of the key challenges we ran into dealt with the use of a licensed clinical care team on the front end. So our care triad, again, we believe we utilize a high touch approach because what we're offering is behavior change support, which needs intervention by humans to help patients follow their plan and answer any questions they might have, and also offer dietary and nutrition support. Is that we were utilizing a licensed triad of a licensed clinical social worker, a registered dietitian, and a nurse practitioner. In employing those and utilizing those licensed professionals, there are a number of regulatory challenges at a statewide level. You have to have them licensed in every state where they're delivering care. And you also need to have them credentialed with payers. So either a payer or a health system has to do a very thorough review of a provider's qualifications, their status, the current status, their insurance status. So effectively, it takes a long time for that to happen, anywhere from 90 to 120 days if that's happening on normally. But with Medicare and Medicaid and government payers, that process could take up to 6 months. So we really were finding that there were delays in the timing that we wanted to be able to circumvent by evaluating a potentially new delivery model that could enable us to move much faster and much more profitably, which we'll talk about in a moment. The other another constraint we had in utilizing a licensed care team has to do with pricing, controls on pricing and incentivization and referrals. So there are government regulations around your ability to charge less than fair market value for services that are being offered by a licensed clinical professional. So therefore, offering a new service such as Trellis, we couldn't really offer introductory rates or special trial offers or any type of creative pricing or promotion that deviated from the Medicare or Medicaid fee schedules. So therefore, we reassessed kind of what we wanted to deliver. What was our initial vision and mission with Trellis was to digitize and scale and deliver the resilience method at scale, beyond the Mount Sinai IBD Center, and really democratize access to the method by using an integrated team to help us deliver that. And we realized we didn't need to deliver the method utilizing licensed clinical professionals. We could actually utilize a resilience coach, a trained resilience coach, and a nurse patient educator who could deliver the method as effectively as using these licensed professionals, and ensure that the method, basically preserve the integrity of the method and evaluate the patients and then manage them through their behavioral change. And if by doing this effectively, we're no longer offering a licensed clinical service because we're not providing licensed clinicians in terms of offering any type of clinical care, whether that be diagnosis, treatment, or prescription. We're offering a resilience assessment, a personalized care plan, and coordinating care with the patient to work, with their doctor and also ensure that they stay out of the hospital. So that doesn't fall under any of the regulatory issues around licensing and credentialing or referrals and price incentivization. Therefore, we can basically roll out our service to all 50 states immediately, and we have a lot of freedom in terms of pricing as well as promotion for any type of introductory rates for our direct to consumer. It also enables, what we'll be doing is it enables us to move more quickly as we can now reach all 50 states. We are enhancing our digitization to enable us to more quickly onboard patients. Whereas previously we would require all new patients to come in and have a resilience assessment first with a live human. We're going to be working to digitize that process and bring people in directly, do the resilience assessment, assign a care plan, and then after they have their care plan assigned, they can meet with their coach or their dietitian, or if they have questions, they can speak with a nurse about any type of patient education issues. This also enabled us much more rapid expansion into IBS in order to address the patient populations, the much larger patient population that is more frequently seen by GI doctors than IBD. So with these two conditions, with IBD and IBS, we'll effectively be addressing 80% of the patients that are walking into a GI doctor's office on any given day. So how we plan to roll this out over the next 18 months, as you can see here in this slide. In Q1, we were in the 4 states that we were licensed and just focusing on IBD. Now that we've modified and evolved our service delivery model, we can quickly roll out to the 50 states through the remainder of this year, and also employ automation, as I mentioned, on the front end to more quickly onboard and evaluate patients. So that enables our throughput to be, from being able to intake several hundred patients per month to several thousand patients per month. And what's important about this as well is using this new care delivery model, the cost of that care team actually goes down because we're no longer dependent on licensed clinical social workers on the front end who are expensive and who are also hard to hire and recruit because they're in high demand due to all of the challenges regarding mental health professional services associated with the pandemic. So we still utilize licensed clinical social workers as for training and quality control. To make sure that our coaches, our resilience coaches, are trained accurately on the method, and that they know how to contextualize a patient case to apply the method and do the resilience assessment. But they will be used for quality control purposes and training, and will not be interacting directly with our patients. So that also helps ensure the quality and preserve the quality of the method. And then as we get into next year, in the first half of the year, we will have the ability to begin servicing IBS patients. So we expect we're going to see significant ramp up beginning in the first half of next year to enable us to begin to onboard several thousand patients. Both, we'll be onboarding for both B2B and DTC, but many thousands of patients in DTC at a much more rapid rate through the enhanced automation that we'll be utilizing. So in terms of financial highlights, I don't know if I want to turn it over to Richard, our CFO, and he can speak to the delivery of what we were able to achieve in terms of financial highlights for 2021.
Thanks, Monique. So not many words on this page, but there are a couple of sentences that are very, very important. So we've managed to make $4.3 million capital investment in the technology platform. That's what Monique mentioned earlier on, the Elevate platform. And that sets us up with a core IT platform in order to do the business in the future. We have 1 or 2 adjustments to make through the movement to DTC, but that should be finished by the end of August. And we will have a very, very good and very sound IT platform. Despite the lack of revenue last year, we still managed to finish the year with net cash of $32 million. And I can tell you, just because I'm sure you're interested anyway, the question hasn't come up yet, but I think we'll be probably about $19 million at the end of this year and about $14 million at the end of next year. And we will actually get into profitability in Q4 of next year. And therefore, I don't expect us to be coming back to the market to look for more cash. How are we going to do all that? Obviously, is encapsulated in the last sentence. We're going to have effective cash flow management, which is in line with our business progression. What does that mean? What it means is we're going to put certain hires on hold until later in the year when we actually need the people. So we won't have people on board whom we don't need at the moment. We will also postpone some tech developments until next year, until we really need them. And so we're just being very careful about the way we manage cash. We're not stopping spending money. We're spending money on what we need to spend in order to achieve our goals, but we're being careful. And I think that's the solution to running a good business.
Great. Thank you, Richard.
Thanks.
So in terms of our outlook for, post year end and our outlook for the remainder of the year, as you saw, we are going to continue to focus very closely on our continued discussions on the B2B side with health plans and employers. The good news is now that we have the ability to reach 50 states, we can really meet the needs of jumbo employers who have employees all across the country to meet their chronic GI diseases and address those using our method. We also have, we'll roll out, as we showed in the slide about, the phasing of the evolution of our delivery model to both B2B and DTC in IBD and IBS. And we are in advanced discussions with pharma and other patient advocacy organizations about sponsoring access to Trellis for their patients. And we've had advanced discussions with these entities for over a year now. They're very pleased to hear that we have a new delivery model that enables us to service patients nationwide and not be restricted by a state specific or a geographic region. The automation that we'll be implementing will enable us to much more quickly onboard and engage with patients, so we can increase the intake volumes of patients that come onto the system through DTC. And as Richard mentioned, we will continue to implement cost containment measures to keep our expenses in line with our commercial progress. We will likely be investing more in digital, targeted digital marketing to address the direct-to-consumer opportunity, and as well as we bring more patients on, we'll be bringing more of the resilience team members who are directly supporting our patients in line with that growth of patient volume. So with that, that pretty much concludes the presentation. What I'd like to do now is address some of the questions. It looks like we've gotten a lot of questions, a lot of great questions from our audience.
That's great. That's great. Let me just jump in, Monique, just to give you a chance to take a look at some of those questions. And I'll, if I may, just bring back up the camera as well. So thank you very much indeed to you all for your presentation this afternoon. Ladies and gentlemen, please do continue to submit your questions using the Q&A tab on the right-hand corner of your screen. But just while the team take a few moments to review those questions submitted already, I'd like to remind you that the recording of this presentation, along with a copy of the slides and the published Q&A, can be accessed via your Investor Meet company dashboard. Monique, you're quite right to say you've had a few questions come in. So perhaps if I could just hand back to you just to read out those questions and where appropriate to give a response, and then I'll pick up from you at the end.
Certainly. Thank you. So yeah, a lot of questions here. So let me just go through and all very good questions. And thank you everyone for your attention and for your interest in Trellis Health and our progress to date. So one question is, when would you expect revenue in the DTC business to start to build sharply? So as I mentioned, as we build the automation of our DTC through the remainder of this year, we're going to start seeing that taking off more in Q4 of this year. And then into next year as we're able to address IBS. So really the IBS market being tenfold the size of the IBD market gives us a lot of capability to expand. And by the end of next year, we will be expecting to see tens of thousands of DTC patients on board, whereas this year we'll see a few thousand by the end of this year. And that will clearly drive revenues in line with the number of patients. Hold on. One good question. What should we look out for news-wise in the near term? So clearly we've been having many discussions both on the B2B side and on the DTC from a sponsorship side with health plans and with our potential sponsors and pharma. So we do expect that we'll be announcing a few of those in very short order based on this new delivery model and our ability to service patients nationwide. We have been, as I mentioned, in negotiations with a New York State health plan that we were very close to signing another demonstration program contract with. We just need to go back to them with this new delivery model, which actually makes the contracting process much easier and quicker because we're not utilizing licensed healthcare professionals, and therefore the contracts are not as complex, and we don't have to wait for the credentialing process to slow us down. Let's see here. When do you expect the results from the Mount Sinai test? So Mount Sinai is not actually a test, it's a demonstration program by which we are enrolling and engaging about up to 25 patients who are our employees at the Mount Sinai Health System who have IBD. And so the demonstration program actually started in Q1 of this year, and we have begun enrolling patients in active care management. It typically will take 6 months, as Marla mentioned. It's a process. This is behavior change is not something that happens overnight, and it doesn't just happen by doing some meditation. So really, we target what the patient needs to work on, and we work with them over a period of 6 to 8 months. So we do expect that we'll start to see, we will see data immediately in terms of how the patients are engaging with the system, and we can do patient satisfaction surveys. But in terms of the outcomes from the utilization of our method through Trellis, it's going to take us about 6 months to start seeing the actual data on those patients. Let's see. In institutional markets, are there any indications that there is more need for proof of efficacy? It's certainly one of the things we've heard consistently from the payers, the health plans and employers is, while they're incredibly impressed with the science and the results that have come out of the IBD Center that were published, they would really love to see more data coming from us as Trellis in terms of patient engagement, patient interaction, as well as the actual health outcomes and health economic outcomes that we're expecting. So that was one of the reasons we accelerated our DTC program, is that we could just, instead of waiting to have B2B contracts signed and bring patients in, we wanted to get patients on the platform, start engaging with patients, get the data, because that in turn will drive advanced adoption through B2B by demonstrating our own results. What are the difference in pricing and returns in the retail market relative to the institutional market? So I'm assuming the difference is, what are the difference in pricing and returns between the B2B and the DTC? So the pricing model in B2B remains the same in terms that we charge a screening fee as well as a monthly active care coordination fee. And then in the DTC, we're charging the monthly price. So we're starting out in terms of our monthly pricing for DTC at a rate of $79 per month, which we will be discounting for the first 6 months down to $49 per month as a special introductory offer to build awareness and to bring on as many IBD patients as we can, in the first 6 months of go live. And we're literally just rolling out this program as we've changed our service delivery model so that we're reaching out to patients and GI providers now to begin referring their DTC patients in using that pricing model. The B2B model had always been a certain price, which we had included in our admission document. We will be lowering the B2B pricing model slightly to reflect the fact that we're no longer using licensed clinical social workers on the front end. Therefore, we can offer the screening fee and the care management fee at a slightly lower rate, which actually is beneficial to our payers, the health plans, the employers, because therefore, if we're still incurring or resulting in a 20% savings, they're going to get a better ROI on their program costs from utilizing this new service delivery model. The payers, what they really care about is, again, that we're able to predict the patients who will be high utilizers and keep those patients out of the hospital, which we'll still be able to do consistently with this new service delivery model. So those are the differences. And in terms of profitability, both of these models, the profitability increases significantly with the greater number of patients that we get on board, especially DTC, which is a very highly automated proposition. So I believe that addresses that question. I don't know if, Richard, you have any other comments on pricing and returns between the B2B and the DTC markets.
Well, just to give a little indication, I mean, you can expect a blended margin next year of about 60 to 70%. And the margins will rise in 2024 over 100%. So I think it's a very, very healthy outlook for the company.
Great, thank you. Next question is, when do you feel one or more large pharmaceuticals will sponsor patient access to Trellis? Well, we're hoping that will happen sometime this year. And we have been in discussions with all the major pharmaceutical companies in the IBD space. I mean, and that's primarily attributed to the fact that our co-founders have, their reputation, the reputation of Mount Sinai and the science behind what we're doing, the relationships that they have with those companies. They've been able to introduce us. We've had preliminary discussions. Actually, we've had several discussions in advanced stages about being able to offer these very important behavioral support services to their patients to enable the patients to stay compliant with their treatment plans and offer them support beyond what a typical pharma support service can provide, which is primarily just kind of questions associated with how to take a medication or administer a medication or any side effects. So our service goes way beyond that in terms of the many more questions and issues that patients struggle with around complying with the medication regime. Lastly, let's see. I believe that is it. If there are any other questions that we have, we are
I think you've
Yeah.
addressed everything that's come through. I think that final question, I think Miles took back, I think you had answered that as well. So thank you, firstly, to everybody that's submitted questions this afternoon, and thank you, Monique, to you and the team for taking the time to give your responses. Monique, I'm shortly to redirect investors to give you their feedback, which I know is particularly important to the company. You'll get their views and their expectations. But perhaps before doing so, I could just ask you for a few closing comments just to conclude with.
Yes, thank you very much. Well, I want to thank everyone for watching today and for all of your thoughtful questions and for all of your support over this first year as we've gone public and we've built and launched our platform and rolled out to patients. We have a very exciting year ahead, as you can see, with the automation and the expansion across 50 states and into irritable bowel syndrome. And we're really looking forward to announcing many important announcements regarding contracts, both B2B and DTC, to bring many more patients onto our platform. So thank you again for your time, and have a very good afternoon.
That's great, Monique. Thank you very much indeed, and to the team for updating investors this afternoon. Could I please ask investors not to close this session, as we'll now automatically redirect you for the opportunity to provide your feedback in order that the management team can better understand your views and expectations. This will only take a few moments to complete, but I'm sure will be very gratefully received by the company. On behalf of the management team of Trellis Health PLC, I'd like to thank you for attending today's presentation. That now concludes today's session, and an early good evening, should I say, to you all. Thank you.